Well, good evening, everyone, and welcome to this webinar co-presented by MHPN and Emerging Minds. My name's Chris Dolman. I work with Emerging Minds, the National Workforce Centre for Child Mental Health, and I'm really delighted to be joining you this evening along with a great panel and a really interesting topic. Tonight's webinar is the 24th webinar in this partnership between MHPN and Emerging Minds. The title is Supporting the Wellbeing of Infants and Children Through a Trauma-Informed Lens. So, yeah, thanks so much for setting some time aside tonight to join us. Or indeed, if you're watching this recording down the track, welcome to you as well. As I mentioned, this is such an interesting and invigorating topic, and you know, it's not by chance that you've been drawn to this. So we're really looking forward to responding to your questions through the evening, and yeah, engaging in a really interesting conversation as we proceed. We've got about nearly 1,000 people, or just over 1,000 people that have joined us so far. So yeah, welcome to everyone. I'd like to move on to the next slide as well. Thanks. And as we proceed, Emerging Minds and MHPN wish to acknowledge the traditional custodians of the lands across Australia upon which our webinar presenters and indeed you are located as well. We wish to pay respect to elders past, present and future for the memories, the traditions, the culture and the hopes of Indigenous Australia. So also, actually, before I speak a bit about some of the other webinars in this series, you know, we're also very mindful there are people joining us tonight who are going through some very difficult times due to floods in Queensland and New South Wales. So, yeah, welcome to you. We're mindful of that as we speak tonight, and mindful of children's experience of that as well as we speak tonight. So yeah, this is the 4th webinar in the 4th series on infant and child mental health that we've presented. There's a couple more coming up in the next couple of months. We've got one in April, early April, around the theme of assessment and engagement with infants and children. And also in June, the title was Building Parents' Understanding of Play to Promote Infant Mental Health. So again, some interesting topics, and certainly ones that will complement some of the themes that we speak about tonight. You're really welcome to click on or to follow that link and subscribe to Emerging Minds newsletter to hear all about upcoming webinars and other things. So next slide, thank you. Okay, you would have already read or seen the learning outcomes, so I'm not going to go through those right now, but just to sort of mention that they're being available in the materials that have been circulated. So next slide, thank you. Yeah, okay. So it's my pleasure now to introduce the panelists for tonight. You've also had the chance already to read each of their bios, so again, I won't go through those now. Instead, I thought that perhaps we could ask each of them a different kind of question. And so, firstly, I'd like to welcome Jasmine McDonald. Welcome, Jasmine. And for you, as a researcher, what is it that draws your interest to this area of infant and early childhood mental health?
Hey there, Chris. Thanks for having me here today. I think the most appealing and challenging thing is trying to understand the child in context as, the things that we observe and that we're researching and practicing within are a normal reaction to an abnormal situation. And that brings with it a whole range of complexities in research in terms of the different kinds of experiences a child might have, how this is experienced from one child to the next, the time that's passed since the exposure, and then that other level when we're talking about infants and children is unpacking and understanding the overlap of trauma reactions or the kinds of symptoms we might see and other developmental changes that might otherwise occur.
Great, yeah, so some of that complexity I think will be present with us tonight, won't it, as we sort of explore this theme. So yeah, thank you for that, Jasmine. I'd also like to welcome Catherine Linton. Welcome, Catherine, to you as well. And Catherine, as a social worker working in this field, what is it that you find is most sustaining of you as you do this work?
Thanks so much, Chris, and it's an absolute pleasure and a privilege to be joining you tonight. What sustains me is how much hope that I continue to have that things can and do get better for children that have had really tough times, and the important people in their life that can support them to feel better and more connected in their relationships. And the more that I learn, the more I realise I don't know. And so one thing that really sustains me is listening and learning to other people who might have a different perspective or a different way of knowing or a different wisdom.
Yeah. So hearing those different wisdoms, different perspectives, is something that can support us as we continue to do this work. Yeah, from
absolutely.
Yeah, thank you. Thanks, Catherine. Yeah, looking forward to what you've got to say later today as well. And also, yeah, so welcome to Alma Jane O'Donnell. Alma, it's lovely to have you joining us and bringing your expertise to this conversation. In your leadership role, with practitioners working in this field of infant and early childhood mental health, as you work with these other practitioners, what is it that you're most keen to kind of encourage in their practice?
Hello, Chris. Hello, everyone. Look, Chris, I think what I'd like to encourage in practitioners in infant mental health is when children and experience trauma, there's a lot of complexities that occur around them, and quite often as professionals the child actually gets lost in the decision making. With foster care placements, with all the other complexities happen, often we forget about the child and they become quite invisible. So I would ask everyone out there to keep the child in mind, always think about, are we keeping this child in mind?
Thanks, Alma, and yeah, we're looking forward to sort of how that key idea, I guess, plays itself out in practice as we go through our conversation this afternoon. So yeah, thank you very much for that, and looking forward, to your contribution as well. So, folks, the conversation this evening is based on or inspired by a case study as well that was just distributed prior to this webinar, featuring a boy, Jack, and his foster carer, Lisa, and also his early childhood educator as well. So I hope you've had a chance to read that. We'll be referring to that a bit through the evening. As we were preparing for this webinar, all the panellists felt it was important that we mention a couple of things about the case study right from the start. And we're keen for me to sort of, on their behalf, mention that we'd like to acknowledge that the ideas and the perspectives that we're speaking about, that are being considered this evening, come from a place of Western medicine, Western understandings about the world and life, and therefore, don't fully, encapsulate all ideas, all wisdoms, all ways of knowing, all local knowledge. And also that we need to be mindful that, we don't fully understand how culture and history and the impact of colonisation and invasion have shaped children's experiences of trauma as well. And so as we consider this case study of Jack, we know that the case study does not disclose the cultural background of Jack, and so as we've had to remind ourselves, we also invite you not to sort of make assumptions about Jack's cultural background or ethnicity as well, or indeed, I guess, the people that you support in your work as well. And that we're really coming to this conversation from a place of not knowing and curiosity as well. So with that as a bit of a foundation, I'd like to now invite our first panellist to speak. And Jasmine, welcome again. Yeah, over to you.
Thanks so much, Chris. Okay, so some of the infants and children that we work with are exposed to potentially traumatic experiences that can present significant challenges to their development and their well-being. This is because infants and children are vulnerable and they're dependent on the adults in their lives. And also because this developmental period is one where there's rapid changes in brain and also skill development. So when we're focusing on complex trauma, we're talking about cases where the infant or child has experienced repeated exposure to severe stresses or potentially traumatic events over an extended period of time. In Australia, the most common kinds of complex trauma experiences are physical, emotional or sexual abuse, neglect, and family and domestic violence. And it's important to keep in mind that every child and their situation is unique. And so there is expected variation in the outcomes of complex trauma exposure. Some things to keep in mind here include factors that increase the likelihood of long-term and severe effects, like when trauma experiences occur earlier in a child's life, have a longer duration, or involve multiple forms of trauma experiences. And we can see from the case study that Jack experienced physical and emotional abuse from infancy through to about 3 years. And so the risk of negative long-term effects is elevated. On the other hand, these are areas that factors that can support positive outcomes and recovery include having a caregiver who is stable and responsive, applies positive parenting practices, believes and validates the child's trauma experiences, and can self-regulate their own emotions. So we're looking to Lisa as the foster carer here to support Lisa and to kind of support these aspects. And we're also looking to Jack's teacher and other people around Jack to form a positive emotional support network. So today I want to focus on a couple of changes that children can experience in response to complex trauma, the areas of stress responses and of brain development. So when a child perceives that there is a threat present, there's a stress response survival system activated. And this is our sympathetic nervous system, which sends stress hormone messages throughout the body to prepare the child to face a threat. And this is what we usually refer to as that fight-flight response. So you can think of your own experiences of this if you consider the last time you're asked to do some public speaking. The blood rushes from your digestive organs to your larger muscles so that you can run away or fight, and that's what causes those butterflies in your tummy. The blood rushes to the front of your brain so that you can make smart, quick decisions. Your blood pressure increases, your hands get sweaty, and interestingly, a natural painkiller is released so that pain doesn't stop you from fighting or running away. But with infants and younger children, fighting off a threat is not an option in the same way as it is for others. We may see aggression, but we might also tend to see responses of increased vigilance, agitation, or anxiety. So in Jack, this explains the teacher's concern of him being on edge and tense or being easily startled. Children might also freeze at times of threat. They might have learned that this is the fastest way for the threat to pass with the least amount of physical damage. In Jack's case, this can look like daydreaming or not paying attention. And here is where I want to point something out. Jack's teacher says that there is no obvious trigger for some of the behaviours. And the concern here is that this might be a kind of risk of overlooking trauma and perhaps focusing on something like ADHD. But the key thing to keep in mind is the nature of long-term memory, which works on interconnected webs of association. So not having the same life experiences as Jack, the teacher and classmates may not associate a loud bang of a door closing as threatening, but for Jack, this could have been an early indicator that things were going to get scary. Finally, the excessive and repeated activation of the stress response system means that stress may be blunted or it could be exaggerated, and that there's physical wear and tear on the body and impact on the connections between cells in Jack's brain. And all of this takes time and experience to reverse or to adjust, and it doesn't just kind of shift when Jack's environment changes. Alrighty, so in terms of brain development, the first 3 to 5 years of life, in those first 3 to 5 years of life, particular brain regions and establishing connections between them are particularly susceptible to disruption caused by complex trauma. Changes in these brain regions can contribute to a lot of common symptoms of complex trauma, including social, emotional, and behavioural difficulties. They can also contribute to various child developmental issues, things like speech, language, and cognitive difficulties. Because these are those higher order functions that depend on the cerebral cortex, that squishy outer wrinkly layer of the brain, brain regions that develop later than the part of Jack's brain that's responsible for perceiving and responding to threat. And this excessive and repeated activation of the stress response system can interfere with the development of things like speech, comprehension, and cognitive abilities, like focusing attention on a single task at a time or using working memory. So even seemingly straightforward tasks like counting out loud in class or holding a conversation with peers requires the ability to hold information in our head and to do stuff with it. So we have to do all that while screening out irrelevant information from the environment. And it also means that impulse control can be reduced, which can lead to other learning and social challenges for Jack. Okay, so in finishing up, I just want to highlight that a trauma-informed perspective suggests that the struggles Jack faces should be viewed as part of his way of adapting to a traumatic experience. Specific behaviours might act as coping mechanisms, like Jack having a preference for being in control as a way to cope makes sense in the context of a world for him that was historically unpredictable. Also, things like withdrawing or refusing to take part in particular tasks might be a strategy to avoid situations that could trigger strong emotions. And some of the behaviours we see might actually be reenacting trauma. So, for example, in Jack's case, aggressive behaviours or being controlling in relationships. So those were the key things that I wanted to highlight, and I'll throw back to Chris.
Thanks very much, Jasmine. Yeah, really interesting details there, and thank you for laying that really solid foundation, yeah, for the remainder of our time together as well. And yeah, so thank you for that. Looking forward to your contributions as we go through the Q&A. I would just like to mention there's been a couple of questions already. Yes, we are recording this webinar, and it will be available on the MHPN website and also via the Emerging Minds website as well. So, okay. So now I'd like to hand over to Catherine Linton, who's going to bring another perspective to this case study and this area of practice. Thanks, Catherine.
Thanks so much, Chris, and thank you so much, Jasmine, for a wonderful start to the webinar. So my perspective is building on what Jasmine has shared, and I'd like to take a moment to really take a deep dive into brain development for infants and small children. When we're looking at brain development, I think the most important thing to do is start from the very beginning, which is the brainstem, and looking at the importance of brainstem function and how this is impacted by trauma. And the brainstem starts to develop when a child is developing in utero and is pre-birth to about 8 months of age, where there's rapid development in the brainstem for basic survival functions. These are things like, blinking, breathing, sleeping, so on. These are the really basic tasks that are incredibly important for a baby to develop, and we really need to hold that in mind when we're thinking about the impacts of really scary or traumatic things that might be happening to a mother that is pregnant or an infant in the first 8 months of their life. The next thing I'd like to consider is the cerebellum, which is the motor centre, which starts to develop from birth to around the age of 2 years, and this is the motor centre of the brain. And this is when babies and toddlers start to get control of their fine motor skills, like being able to pick up a sippy cup or to bring their foot to their mouth, or all those sorts of things, starting to crawl. These are really important tasks that babies and young children start to develop around from the age of birth to around 2. The limbic system is the emotional part of the brain, and this is the part of the brain that babies and young children really need support from their parents or caregivers to help them make sense of their big emotions. And children around the age of 2, we often refer to the terrible 2s, but that's because 2-year-olds are really feeling then acting. They've got no capacity to think then act. So and they really need their parent or their caregiver to be very attuned to them to help them make sense of the world and make sense of these really big feelings that they're starting to experience. And the cortex, the thinking part of the brain, starts to come online from around the age of 3 to 6 years. And this is when children start to develop skills in reasoning or making sense or starting to make decisions. If I do this, then this might happen. So this is just really important to keep in mind as we move to the next slide. So we'll often talk about brain development from being bottom up, and that's correct, but I'd also like to think about brain development as being horizontal and looking at the different hemispheres of the brain. And when we're looking at brain development from bottom up, there's also brain development that's going right brain and left brain. And we can think about right brain being the emotional center of the brain and the feeling center of the brain, and the left-hand side of the brain being more thinking, logical, numbers sort of thing. And so in the right-hand side of the brain is developing from birth to 2 years. So when we have a child, such as Jack in the case study, who's experienced trauma in utero and then birth in the really early years, he's going to have likely to have trickiness in some areas of his lower brain stem and his right-hand side of his brain, because that's the part of the brain that was developing the most significantly in his time of trauma. And when children are experiencing trauma, particularly in their early years, their brain focuses its energy in right brain processing, of trying to scan for threat, looking for danger, becoming really attuned for people's tone of voice, not what they're saying. They're listening for the tone of voice. They're looking for your facial expressions because they're trying to work out, are you a friend or a foe? And so from the ages from about 2 to 4, children who are developing typically tend to be more left brain focused, and they will start to be saying why, and that can be really, really frustrating for some parents and caregivers, but it's a sign that their left brain is developing. And then it can switch over back to right brain from the age of 4 to 6, where they're starting to make sense that they have feelings and that their feelings can influence their world. And then it flips back over 6 to 8 years to the left brain, where they're starting to really get a grasp of the more thinking, logical parts of the brain. And then after that, things tend to develop quite equally in terms of left and right brain development. But it's really important to keep in mind when a child has grown up in a world that is scary or traumatic or unpredictable, the brain will do anything it can to keep itself safe, and the brain will do anything it can to survive. And that means that a child's right brain is likely to be most used. So children will often have difficulties with being able to follow instructions or without being able to count or to follow order, because they can't listen to that. They're listening to the educator's tone of voice. They're looking at their carer's facial expressions. They're not able to understand the language. Even though there's not a language deficit, their right brain is looking at, how do I survive this situation? So next slide, please. So at Australian Childhood Foundation, we like to think of brain development as being a little bit like the common game of building Jenga blocks. And hopefully most of the people on this webinar would have played Jenga, so they know what we're referring to. But if we're looking at Jenga blocks being built as a tower with a really solid foundation, which is the brainstem, and then moving up through the tower of the brain, if children have experiences that are repeatedly attuning to their needs, that they're being rocked and soothed, they're being attended to, if something scary happens, someone is able to attend to them and soothe them, their brain will develop a Jenga tower which is strong and solid and can withhold greater challenges. However, if an infant or a young child is exposed to prolonged toxic stress, the brain is unable to build this solid tower, and it's going to adapt to that toxic stress, and lots of connections in the brain aren't going to be able to develop. So when something stressful does happen for a child, they can experience that as being completely overwhelming, and they're not able to access the resources that, that other children might have available to them to be able to manage a scary event or a frustrating event. Next slide, please. So one of my key messages is that children communicate to us through their behaviour. Many children, and some would argue lots of adults, don't have the words that they would like to have to explain what they need or what they think and feel. But children really, really do show us what they're feeling through their behaviour. So when we're considering children such as Jack in the case study, we need to be looking at it through the lens of an iceberg. What you see above the water is the behaviour, but as the caring adults around Jack, we need to be asking questions of what is this trying to communicate? Is Jack feeling loved? Is he feeling confused? Is he feeling angry? Is he feeling like he can do things for himself? And if we start to ask these questions of what is his behaviour trying to tell us and focusing on his unmet needs, it can help us make a lot more sense of what do we need to do differently to support Jack. Next slide, please. When we're thinking about trauma, the impacts of trauma does cause fragmentation for children, and a child's sense of self will be fragmented across every part of their world and their system. So the trauma impacts the brain, the body, the memory, emotions, behaviour, learning and relationship. All of these things are impacted by trauma and causes fragmentation. The brain can't make sense of the world when all of these parts are fragmented, and that's really important to keep in mind. Next slide, please. And we sometimes talk about a child being in a trauma world versus a now world. And that's really important to keep in mind if a carer or a parent may have had a child in their care from birth or really early on, and it can be really hard to understand why a child continues to be impacted by trauma even though they've been in a really loving, safe home for many, many years. Because of the way that the brain has built itself to protect itself, to try and stay safe in the trauma world, triggers can really pull a child back into the trauma world while the brain tries to make sense of what scary thing is happening in the now world. Like Jasmine referenced a banging door. That can not be a bother for many people, but for a child with trauma, it can be a huge trigger that something very scary is about to happen and pulls them back into a trauma world, even though the now world might not have had a scary thing happen in it for a very long time. So it's really important to recognise that children who have experienced trauma have a foot in a trauma world and a foot in the now world, and they need many, many, many thousands of repeated experiences of safety to help them get both feet in the now world. Next slide, please. So Dan Siegel developed a model called the window of tolerance, and some people prefer to call it the window of capacity, which is a bit more strengths-based, but Dan Siegel is one of my heroes, so I'm going to call it the window of tolerance. And the way that he references this is that ideally we'll always be in our social engagement system, and that's where you might feel safe, calm, able to engage with people. We're within our own window of tolerance. But when something scary happens, like you have to do public speaking or, a door bangs, you might go into your social defense system, which might be activating the fight, flight, or flight or active freeze response. And the body is amped up for action. There's an increase of adrenaline, heart rate goes up, the breathing and muscle tension increases, and the person's very alert or reactive. And this is really the brain saying, this is very scary, I need you to fight or flee to survive. if the brain determines that the threat is insurvivable, the social defense immobilization system will be activated. The body's not able to fight, so it shuts down all the non-essential systems. People might look like they've internally collapsed or become submissive. They might disassociate. They might feel numb. And some people experience things like loss of bowels, decreased heart rate, breathing, and muscle tension. And for some children, this looks like compliance in the school. And for many, many people that I've spoken to, they might say, well, this child's not a problem at all. They're so quiet and there's never any trouble in school, so they don't have trauma. However, if they have a history of trauma, it may be that their social defense system is activated and they're quite immobilized and shut down. So it's really important not to mistake compliance for just compliance. It actually may be a sign that a child has slipped out of their window of tolerance. Next slide, please. So we talk about therapeutic parenting a lot at the Australian Childhood Foundation in terms of how do we support children who have experienced trauma. And therapeutic parenting under the PACE model was developed by Dan Hughes, and for the clinicians who are on the webinar, I'd encourage you to look at Dyadic Developmental Psychotherapy, or DDP Dan Hughes, is much easier to Google. And PACE stands for being playful, accepting, curiosity, and empathy. And it's not a model where you do playful first and then move to accepting and then move to curiosity. It's an overall framework that offers the adult a way to respond to the child to try and meet their needs. And if a child is feeling really enraged about something, sitting with acceptance that that's the way they feel right now without trying to change it, giving them some space, and then it might be empathy. I can see this has really got you stirred up. I can see this is so infuriating for you. Being playful in that moment is likely to be incredibly inflaming. So it's very important that if a person is using the PACE framework, that they're using their discretion and thinking about what does this child or adult need in this moment. And so again, Dan Hughes' PACE would be something that I'd really encourage everyone to have a look at. Next slide, please. And my final point is about support for Jack's carer, Lisa. And for children to do well, we need to really support their important adults and the people that are supporting them. And for parents and carers that are in this space, I really want to acknowledge that you do an incredible job. And there's a Zulu proverb that I really like, which is you cannot wipe the tears off another's face without getting your hands wet. And I really want to acknowledge that when we are working with people with trauma, it does have an impact on us, and self-care and really supporting yourself and taking time for yourself, seeking professional support is the only way that you can you engage in the marathon that is parenting, or in the marathon that is therapeutic parenting for children with trauma. Thank you again for having me here tonight, and I'll hand back on to Chris.
Thank you so much, Catherine. Yeah, really some significant messages right at the end there, but also throughout, really. I think some of the concepts that you've described really offer practitioners and indeed parents, I guess, a different way of understanding children's experience that can perhaps open up different possibilities for how to respond. So, yeah, look forward to hearing more about that as we go through the rest of the evening. So thanks once again. And, yeah, I'd like to now hand over to Alma, who's going to bring her practice experience to this webinar. Thanks, Alma.
Thank you, Chris, and thank you, Jasmine and Catherine. I'll try not to repeat too much of what you've already spoken about. What I wanted to speak about tonight is to really think about the theory that we all know and that we've been learning about, and how do we transform that into everyday practice within our work. And in particular, I want to talk about how we enter into Jack's world. Earlier on, I spoke about not losing sight of the child, and one of this, what I was sort of meaning by that is that quite often when we have lots of placements and there's lots of, psychology appointments, OT, speech, we've got Jack from place to place. He's going to access visits, he's going to appointments. So what would be really good to do is really bring all our services into Jack's world. So let's look at entering into Jack's world and see what we can do with our skill base in Jack's world. So next slide, please. So what can we do? As I said, taking your service to Jack. Does Jack need to come to you? Or can you go to his early learning environment? He's there all day. It's a familiar zone. It's not inconsistent like his foster care placement. He's known this teacher. He's got a great relationship. He's known her from 3-4 years of age, and maybe a bit longer. We're not quite sure. So can you bring your service to Jack? Think about 1 hour therapy, or embedding all your practical interventions into all his all-day activities, just little things that he does throughout the day. Is there things for our OTs out there, our speechies out there, our play therapists? Are there small things that can be embedded through his early learning experiences throughout the day that you could share with the education team? This will help Jack make sense of his world. When you've had so much disruption, you've had a teddy bear that was here, and you've got pictures, and you had a favourite dog over here and an auntie or a neighbour, and it's all fragmented. And so we want Jack to make sense of his world. So if we bring everything into his space, that will help him make sense of his little world rather than offices and transportations and taxis. So that's quite powerful. So we know that ECEC, so early learning, can provide the opportunity for the traumatised infant to form relationships that Jasmine and Catherine have talked about, that go beyond foster carers and really come around him. So, but educators do need to be supported. So that's why sharing your skills with the educators. We're not asking educators to be therapists, but there are some simple things that you can bring from what you know and share that with the education team for training sessions, or just sharing some of those simple things, or doing your sessions at the centre. Even having access visits at the centre as well. You could consider that. Next slide, please. Now, we won't go too much because we've talked about, but I want you to consider Jack's brain development, and let's move on to the next slide. So we're thinking of Jack's brain development and where the trauma has occurred. Ask yourself, what age is Jack actually developmentally? And especially think about his social emotional age. One of our biggest reasons that our 5 and 6 and 7-year-olds are excluded from school is not because they haven't been able to do their maths or do the cognitive thinking or, English or art. They're excluded from school because their social skills are quite poor, and they can't connect with their peers, and they have explosive, hit their peers, bite their peers. That's the main reason children are excluded from school. So what we want to think about is, now the story tells us that Jack has been in the kindy room or pre-kindy from 3, then he moves up to kindy, and they're starting to see a bigger difference in how he's engaging in the environment. He's becoming more volatile, there's more withdrawal, which from a side note, from a science sort of side of things, that we do know around the age of 3 to 4, the exacerbation of trauma, whether it be volatile or withdrawal, really exacerbates between that age of 3 to 4. So we're seeing that in Jack's story as well. And so then we're thinking about his peers. So his peers, as Catherine said, typically developing children will move to a different way of engaging relationally and thinking, where if Jack has experienced his trauma at a certain age, he may be predominantly a lot younger socially than his peers. So he could be functioning around the 2.5, year 2 to 2.5-year-old, where his peers are now entering 3 to 4, 4.5, which is quite a massive difference in our social skills and our ability to understand, oh, hang on, think this could be a consequence here, versus if Jack is sitting quite developmentally back with age. So thinking about that, does his age then match the classroom expectations? So often in our classrooms, we might have quite independent play happening. We might have scissors left over here and cutting up, or some really amazing STEM activities happening that actually require quite a lot of independent learning and focus. Now, if we think about that, we have a classroom set up for our 4 to 5-year-olds as he is, but functionally he's socially around the 2.5. We think about what would happen if we had a 2.5-year-old in that room, and that what will happen is what we're seeing. So we need to think about what are the expectations? Are they actually matching Jack at his developmental age? So next slide. So what we know is that when children suffer trauma, they miss critical developmental stages. So we need to allow them to go backward to recapture those stages. And that's the answer to healing and going forward. So we can't just expect Jack's gone to kinder room, so now he needs to be doing therapy to get him to be functioning at the kinder level right now, because Jack missed out those developmental ages. It's like expecting a child in toddler nursery just because you put him in toddler room that they can walk. So we've got to think about what are our expectations and where do we need to start with Jack to be able to scaffold for him to be able to develop to the stages of his peers. Next slide. So this is the amazing part that you can all do. You can share your knowledge with educators. You all have different disciplines that you can share your knowledge with. So our OTs can go into the environment. Oh, sorry, next slide. I forget about that. Sorry. So what we can do, think about our OTs, think about the environment. You can go into the early learning environment and think, how loud is that room? How many doors are banging? Because as educators, they're immersed in the world of education and the curriculum. As an OT lens, you're going to be bringing in the environment. For our speeches, we can bring in and thinking about the scaffolding, the language for this little one. In our play therapists, we could be thinking about, are there certain types of play that we could introduce? Also thinking about our social workers, can we have all our case meetings as much as possible that come around, Jack, are we involving our early learning centres in those, or can you even go there for them? So thinking about the noise, we talked about noise banging, movement, very predictable. I mean, little children are the most unpredictable children really, aren't they? They're the most, up in the face, and their personal space, is quite hard. And one of our things that sometimes our early learning centres use is this stop. I don't like that. Now, as we know with children from Jack's background, a hand in the face with a stop is never going to eventuate to anything safe for him, regardless of how safe he thinks, you think you are. So we might think about, are we encouraging his peers to do that? That might not be the best thing for him. Predictable routines. When you know what's going to happen, your anxiety levels are down. So we need to create a very predictable routine. His access visits happening the same time. Are we communicating with the early learning centre saying, Jack's access is at this time, what's going to happen? Will there be the same routine? He'll have his lunch, he'll go to access visits, he'll come back, he will do this. Same with any appointments. It has to be very predictable and avoid those ad hoc, oh gosh, quick, we can get something in now. So next slide. The PACE model, I think, described this. I think Catherine described this beautifully. This isn't actually the PACE model, but this is exactly what Catherine was talking about. Children need to really internally experience empathy and kindness, not just have that read to them. So as Catherine said it beautifully, like, oh, gosh, that must be hard. So they can internalise that feeling. That's the only way they're going to be able to express that. We can do that constantly throughout the day for them. Another great program for a curriculum in an early learning setting is one called the Mind Up program. That teaches all our children about what happens when the amygdala flips. We might think, oh, our little ones won't understand that, but they can learn second, third, fourth languages at this age. So why can't they learn about the brain and what the brain does? And then they also have a bit more empathy towards Jack, thinking, oh, Jack, that's just Jack's amygdala's flipped. That's not Jack being naughty. So we can teach empathy and for our other children as well. Next. The naming initiatives, Mardo Mayo, for all those out there, we know naming initiatives is absolutely amazing practice to be able to do. The narrating the intention of others as well. So, oh, look, Jasmine's coming over to you. She's going to give you a book and Catherine's going to open the door. So once again, we're reducing and then also saying, and Jack, you can sit with us. This is what you can do. So we're going to narrate and make him make sense of his world. Another great thing to do is really create this, given that Jack has come and gone from foster care and his life is fragmented, let's put it in a picture book. So if we've got pictures of Jack at foster care, if we've got pictures of Jack, you know, with his old favourite dog, and put it in a storybook for him, give him his history, because these children often have no history. They don't have photo albums of when this happened and that happened. So we can create that for him. We can give him his story, because when you have a story, then you have a future, and it makes the biggest difference. So we're a simple picture book and asking the educators or our foster carers, read him his story, tell him his story. Next slide. So to finish off, there's throughout infant mental health literature, there's been some amazing articles. One is called Ghosts in the Nursery and another one called Angels in the Nursery. So I want to talk about going from, and you have that in your resources to read. So I want to talk about what studies they did that showed that mothers who'd had a childhood history of maltreatment, but what when classified as abusive towards their own children, usually and compared to those that had a history of maltreatment and then grew up to be abusive. The one common thing they found that what differentiated between the two groups was that they had an additional relationship, something significant in their adult life, but also in their childhood. There was an auntie, there was a teacher, there was a social worker, there was somebody who made the difference, so that when they carried on into their own parenting, they could bring angels into their nursery, not only the ghosts of their past. So Jack, as a little boy, will hopefully one day grow up and become a father. And what we want for him is to bring the angels in from his nursery, not just the ghosts. And we can all do that by coming into Jack's world when he's little. So I'd like to thank you all for listening tonight and inviting me to be part of this session.
Thanks so much, Alma. I really appreciate the way you've spoken about some of the real practical considerations, practical steps that practitioners can take in relation to children's wellbeing and the kind of the air of possibility, that you spoke of these things. Yeah, so thank you so much for that presentation. And thank you to everyone who's been submitting questions for our panellists, both prior to this webinar as well as our panellists have been speaking. And we've had a few questions actually around a particular theme. So someone asked that in their work they meet with a lot of clients who've been pushed to get a diagnosis of ASD or ADHD or ODD. However, when this is explored further, what becomes more apparent is a background of trauma in the child's life. And so the initial question is also, how do you differentiate between these, and I guess the extent to which it's important to do so. So Jasmine, for you, in your perspective, how do you respond to this dilemma around differentiation, if it is indeed one?
Yeah, it's a great question. And that goes both ways when we're looking at neurodivergence and the overlap of trauma, absolutely. So the overlap is really interesting in terms of the symptoms or the behaviours, better said, behaviours that we see in response to trauma. With, say, ADHD, for example, we might have difficulties around attention, arousal levels, and even dissociation. We also see an overlap in the impact on those higher order skills that we've been talking around, like thinking skills and emotion skills. If we think about the overlap with autism spectrum disorder, we can see similarities in terms of social skills and empathy, and rigidity or kind of a challenge in adjusting to change. So I guess the overall concern that we need to think about here is that a treatment that doesn't address an underlying trauma, if that's present, isn't going to be effective at best, and it could potentially be harmful, especially if we're talking about routes that include medication that are not going to be effective or potentially harmful. So I don't think that we have a kind of clear, hey, this is what you need to do, but I can suggest some things that the literature and practice wisdom kind of could point you towards. And that is taking a child and family-centered approach to try and understand the social, emotional and behavioural difficulties that might be present. And really trying to understand, like I think it has come through in all three of the presentations, is understanding the environment and being flexible. That the more and more we're working with a young person who's trying to control their environment and is bringing with them a lot of context we might not be aware of, we actually have to be more flexible to adjust what we do, like Alma said, going to them, and a lot of examples that Catherine provided as well. So in the first session, or the first time that you meet a young person, their family, ask about trauma backgrounds. Practice this. Think about what is a safe way that feels okay for you to find out what might have happened in the past. Even if it's not evident in the first session, it's really important to take a trauma-informed approach with everybody that we work with, because, you know, that really kind of passive young person who sits diligently in a classroom but might internally be suffering might have a trauma history just like that young person who has an approach that is more on the offensive to defend themselves and maybe aggressive or anxious. But yeah, I think it'd be really interesting to throw to Catherine and Alma as well and see from your experience around this.
I think you explained that beautifully, Jasmine. What I would add to that is that there is a real overlap in clinical presentations in terms of ADHD, autism, ODD, and lots of other disorders, and the commonality with each of these symptoms, if we just look at the symptoms, it's really easy to go for diagnosis, and diagnosis can be incredibly helpful in terms of getting early intervention, access to therapies through NDIS. However, if we're rushing to diagnosis, we can, as Jasmine pointed out, miss the bigger picture. And it is absolutely possible for someone to have autism and trauma, or ADHD and trauma. I would suggest that ODD is because of trauma, and I don't think that you can differentiate oppositional defiance disorder from trauma. And
Seconded.
And if anyone has the opportunity to listen to Gabor Mate's explanation on oppositional defiance disorder, I'd encourage you to. I'm not going to do it justice because I'm doing it from memory. However, he talks about oppositional defiance disorder meaning the push against a relationship. So if you've got a person with ODD and then the relationship, the person with ODD is pushing against the relationship. If you remove the relationship, there's nothing to push against. And they're pushing against that feeling of risk in relationship, and that is trauma. That is caused by trauma. So I would argue, and I might get myself in trouble here, that ODD can't be distinguished from trauma. But I think it's incredibly important, as Jasmine pointed out, that we look at a child's whole history, including in utero experiences. We cannot exclude the experience of a pregnant person's trauma from childhood trauma.
Great. Thanks, Jasmine, and thank you, Catherine. There's been a question as well, Alma, in response to some of what you were saying in relation to working with educators, but also if you could talk about some other strategies that practitioners can draw on to support, like Lisa, foster carers in this circumstance as well. What sort of what's possible there?
Well, I think when we think about foster care placement, we've got to think about, have they had that chance to actually enter into Jack's world and really understand who Jack is, and spending that time. And there's a great therapeutic intervention called Watch, Wait and Wonder, and I would encourage all foster carers, when you first have a child placed in your care, just watch, wait and wonder about their little world, and wonder about what it is they're making sense of your environment. But, you know, are they just staying in that space with them, because it's until you understand what's happening in their little world, it's really hard to sort of connect. And that's the best way to learn about what can this little one do. They will often come with a list of medical, as you're saying, Jasmine and Catherine, you know, medical diagnoses. They will tell you everything negative about what this child can't do, but find out, what does this little one love to do? And then you scaffold from that. So if they love to sit outside and, you know, play in the backyard and look at the leaves, well, maybe that's just what you do for the day, if you can. Just start from what they can do, and when you slowly build up, then you can start to maybe move them into spaces that are a bit tricky. But yes, that's sort of what I would say, yeah.
Great. There's also been a question along those lines as well, Alma, just staying with you, when you spoke about naming initiatives, and could you say a bit more about what that actually what you were meaning by that as a practice? Yeah.
So naming initiatives would be naming what the child's initiative would be, but also I think it's important to name, for those who are out there who might have specialised, I hope I do this justice, but it's naming, you know, I'm going to come over and sit next to you, Jack. Oh, you're sitting on the chair, Jack. So my initiative is I'm coming over to sit next to him. His initiative is he's sitting on the chair and he may look at me. And then I might name somebody else's initiative. Oh, they're going to walk over there and they're going to do this. And then again, oh, Jack, you can come and sit over here. So it's naming what their initiative is. But if you do that ahead of time, rather than just always in the moment, it's really good to do in the moment as well. And if you practice it all the time, you may even find that you turn around to your partner and go, oh, I'm going to get a cup of tea. Why are you telling me that? But it's a really great way, especially if our children have suffered trauma, just to make sense of everybody's intentions and makes them feel safe. Yeah.
Great. Thank you for that. I'm just going to move the mouse now, Alma, and I would like to sort of ask a question of Catherine, actually. That was... there's a couple of questions around parenting and responding to parents who have been through difficult circumstances themselves through their life and have developed a distrust of services, right? Yeah. Yeah, and so how do you go about, you know, engaging with those, or how do you go about, or what are some ways of engaging with those parents in those circumstances that you found helpful?
That's such a good question, and thank you to the person or people that have brought that to the front, because I think it's incredibly important in this context. I think in the same way that children will try to keep safe through their behaviours that have worked when they have been through tricky situations, adults will also use their past experiences to try and predict the future. So if they've had an experience that has been unhelpful or unkind or traumatic with a service provider, their adult brain will use that information to try and predict future situations with a service provider. So it's, I think, coming from a place of, like, I get it. Like, of course you feel like you can't trust me. I'm another new person that you have to tell your story to. And it's particularly important if a person is not voluntarily seeking your service. You have a power imbalance that you need to check your privilege, and you need to be able to acknowledge that you do have power in a person's life, and the power is not balanced, and there is going to be healthy mistrust. Of course there is. And I think it would be really challenging for a professional to assume immediate trust with a person accessing the service. I think the most important thing to do is to be genuine, to be authentic, never promise something that you cannot deliver. If you say you're going to call at 4 o'clock, call at 4 o'clock, or send a text message. Be predictable, be authentic, be respectful, be kind, be human, and do what you say you're going to do is so important, and have some empathy. Of course, that of course they are feeling cautious. Of course, because history is the best indicator of the future, and maybe you'll be the person that changes their mind, and wouldn't that be beautiful? But, just being aware of the power imbalance is really important as well.
Catherine, would you mind I'll just add a little bit to that, Chris, too? I think it's beautiful what you just said then. The other thing to think about, too, is that has this parent, thinking about transgenerational trauma, has this parent ever been delighted in? Like, have they ever actually experienced anyone saying you're okay? So something to think about, that if their whole life they've been told growing up that they're not good, then they're being told they're not a good enough parent because they're having to go to these services. Has anyone actually said you're okay? So.
Yeah, I mean, how can you be on? What can you be on the lookout for that can prompt, that kind of conversation with a parent, Alma, like even in an early childhood setting? Yeah.
Well, I think in an early childhood and school setting, it's probably easier to see because they will be the parents that just come in, will have no eye contact. They're just like, take my child, or they will hand a child over and say, yeah, he's been bad, don't worry about it, and leave, because they want to preempt what you're going to tell them. Right. So I think one of the beautiful things to be able to do is those little things like when they pick their child up, or when you see them, to say, oh, your child was so great, did a beautiful little play today. It might have only been 3 minutes, but hey, you don't need to, so just, and leave it at that. Do they actually need to know all the catastrophes that the child has, experienced during the day? It's not keeping things from parents, but thinking, do they need to know everything? No. Can they be told something good? And can they just be told something good for that moment? And so that's where you gain their trust. They'll be like, oh, well, I'm not going to walk in and always hear, this is what your child did today. This is what your child, they're going to hear, oh, your child is very beautiful today. And it's just little simple, because they won't be able to tolerate too much compliments because they'll become suspicious. But it's just those little moments. So.
Thank you. There was also another question, Alma, about flowing on from what you're saying about the angels in the nursery story, and the importance of relationship, I guess. And someone's asked a bit about, sometimes the pressures around time and billable hours and this kind of thing, can make it difficult for that relationship to be built under that sort of time pressure as such. Like, from your context, are there things that you've learned that can contribute to the building of relationship in under those sort of time pressures? Or
well, I think this, often we'll talk about this to my team, is that building relationships is part of the work. So don't think of it as above, like outside of billable hours. The most crucial thing you could do is actually form a relationship, and that in itself is a massive therapeutic intervention, especially for our children, our adults. The very fact of connecting and being, that is your work. So often we think that's something we have to do before our work to get into the gritty of our work, but it isn't. It's core to all our work. So it's thinking about this as part of, if you have to be working in the billable hours sector, then that is part of your work. That is part of your billable hour, is connecting, being, and that's also very, very strong therapeutic intervention as well.
Thank you. Catherine, a question in relation to, I guess, children in Jack's position, children in foster care, but who perhaps might be moving more frequently than what Jack has been moving in terms of his care, and what is it that can kind of be supportive of children through those transitions from one foster carer to another? And also, questions around supporting the foster carers through that as well. I don't think I've brought together questions that well, but is that getting a sense of what people are interested in? Yeah.
Yes, absolutely, and it's a fantastic question. I think it's really important to go back to being child-centered, which I think Alma has touched on a few times, and kind of being able to put ourselves in the perspective of the child. And each time that a child moves placement, the intentions or the goodwill of the carer is not going to be overridden by the child's fear and mistrust. So each time that a child moves, they're going to be scared, and it's going to be unpredictable, and it's another change. And we know that what makes children feel safe is predictability and consistency. So as much as possible for the people that are supporting children moving placements, making things as predictable as possible, telling them who are the carers they're going to go and stay with, who else lives there, are there pets there, what does the house look, do they have pictures of the carers, having a familiar person do the transport, do they have familiar items that can go with them, does the carer have a storybook about themselves or their family or their history that they can read to the child when the child comes into their care, and understanding that the foster carers who offer their homes to children are incredible, and my absolute respect for everything that you do. And we need to put the child first and not assume that having a warm approach is going to mean trust. Trust is earned. And when a child has moved from placement to placement, it's going to take a really long time for that child to feel okay. So it's kind of going back to, what can this child do right now? What can they do to feel safe in this placement? Making things as predictable as possible. I really loved what Alma was saying about, I'm going to go and make a cup of tea now, or I'm going to read a storybook now, and saying things out loud as much as possible to remove surprises. Children will let us know when they don't need you to do it anymore, because I know, or they'll be like, yes, I know you're going to go make a cup of tea, and that will be a sign like, okay, I've done it enough. So as much as possible, making it predictable, and really meeting the child where they're at, and understanding that this child has gone through so much, and each time that they move, that's another relationship they've had to say goodbye to, and that makes it really hard to say hello to the next relationship. So being really, really kind to themselves as carers, accessing their own support is critical, and it really does take a village.
It does.
Thank you, Catherine. And in fact, I'm realising the time, and we might need to sort of begin to finish. I'd like to ask each of you perhaps to mention something that you'd really want to either reiterate from what's been spoken about, or maybe something that's really stood out to you from the conversation we've had tonight. So Jasmine, for you, what's most caught your attention, or what is it most important for you to be mentioning again?
We've covered so much ground, Chris. There's so much, but one of the things I was reflecting on while we were just having that question session is the encouragement around self-care for practitioners. And I realised, earlier I'm asking the first session, be ready to have these conversations, be ready for the personal response you might have to that, and reflect on that stuff and prepare for that, because you need to take care of yourself, but we also need to make sure that the person that we're working with doesn't see in us that body language change or that facial expression that they're so sensitive to, because we might feel uncomfortable in the situations that we're in. So we have to prepare for that. Not really a sum up, but just my last little
Sure.
tidbit.
Yeah. No, thank you for that. Well, good. Thank you, Jasmine. Yeah. Alma, for you. Yeah.
Look, I just think it's wonderful to see that so many people have joined in this webinar tonight, and so I think it really is about, as Catherine said, it takes a village, and we've got a really large village here just to come around our little ones so that they can grow up to build a better world, really, isn't it?
Yes. Thank you, Alma. Yeah, and Catherine, for you, what's most standing out to you, or what would you like to reiterate?
Oh, I would like to have a whole webinar to talk about what, what I'd like to go over. I think for me it's the importance of relationships, and without healthy, secure relationships and doing everything we can to scaffold relationships, we can't do what we need to do to support little people. And little people who've gone through tough times deserve everything. And if we can do better as professionals and carers and educators to really learn about ourselves and to learn about what children need, we can absolutely change the lives of children that have had a tough start.
Yes, indeed. And yeah, we hope, folks, as you've been viewing this webinar, that that kind of emphasis also around possibility, and I think that's something that's really stood out to me from the panelists, possibility and how we, and thinking differently actually about children's experience can open up a whole range of different possibilities for us to respond to them and to their parents. So yeah, thanks so much also for your questions. There's been many that we just didn't get to. At times I've made attempts to bundle them together. So yeah, thank you for all that have submitted questions. Those that we didn't get to, they won't go to waste. From our perspective, we'll be drawing on those and using them to shape other webinars and other things that we produce to support your great work in this area with children and families. So thank you for all of those. I'd just like to bring up, the next slide. Thank you. So we would appreciate it if you could complete, as I said at the start, the feedback survey before you log out. Click the yellow speech bubble icon to do that, and you'll receive a statement of attendance in the next month or so, and you'll also will be sent a link to the recording of this webinar and other resources that the panelists have referred to, and other resources as well that you might find helpful to support you in your practice. Okay, yes, and they're available using that information icon there or on the Emerging Minds website. I've already mentioned the webinars that are coming up in April and June that are certainly connected to this theme. So yeah, please check out those when they start to circulate. And we also, there's another MHPN webinar coming up in a couple of weeks' time around suicide prevention for LGBTIQ plus communities on the 22nd of May. So yeah, look out for that one as well. Okay, so as we finish, just to reiterate that this webinar was co-produced by MHPN and Emerging Minds for Emerging Minds National Workforce Centre for Child Mental Health. And the National Workforce Centre is funded by the Australian Government Department of Health under the National Support for Child and Youth Mental Health Program. Okay, so also, again, a reminder that MHPN supports over 350 networks across the country where mental health practitioners gather to talk about practice and the dilemmas and challenges of practice and the delights as well, in person and online. And so, yeah, check out the MHPN website to see what local networks are, kind of linked to your interests as well. Or if you'd like to start one, yeah, please contact the MHPN around that and get something going in your area or your practice area of interest as well. They'll help you through all of that. Okay, so that brings us to the close. Again, thank you for everyone's participation. Thank you so much to our panellists, to Jasmine, Alma and Catherine, for bringing your expertise and your passion for this work to us this evening. And I've really appreciated it. Look forward to working with you each again at another time. And thanks everyone for joining us. Thanks to the folks at MHPN for the behind the scenes work that goes on, and also to my other colleagues at Emerging Minds for the work they do in making this happen. We'll see you next time, folks. Thank you.